Okay. So I'm Elena Rios, President and CEO of the National Hispanic Medical Association, and it gives me great pleasure to introduce our Duchenne muscular dystrophy and perspectives from the Hispanic community webinar tonight, hosted by our partner Pfizer. And I will be introducing our speakers. They will be making presentations. Let me just go ahead and introduce them now. Angela Kodsi is a pharmacist with Global Medical Affairs, Rare Neurology at Pfizer. And Dr. Bert Johansson is a physician, a pediatrician, and intensive care physician at the Centro de Salud Familiar La Fe, which is a large community health center in El Paso, Texas. And he's also the treasurer and my boss, NHMA Board of Directors.
Yo tengo plata.
I want to thank Vincent Garrity, who is our staff tonight, and for taking the extra time. He works extra hard for us, and Vince, we really appreciate your efforts. And a little bit of housekeeping. Tonight's webinar, we will have two 15-minute presentations, and then we will have Q&A. In order to ask a question, and we encourage questions, please type your questions in the chat box, and then I will moderate and ask the questions to the speakers. The microphones will all be muted, and a recording of this webinar and our slides will be available next week at the NHMA website, which is www.nhmamd.org. So with that, I'll introduce our first speaker to go ahead and speak. And again, that's Dr. Khadzi, Angela Khadzi from Pfizer.
Well, thank you so much, Dr. Rios, and good evening, good afternoon to everyone. It is really our pleasure to be with you today, and I want to thank NHMA for the outstanding partnership. It's been a pleasure. So we're looking forward today to share with you an update on Duchenne muscular dystrophy and the perspectives from the Hispanic community. Before we get started, just a quick disclaimer that my presentation will include forward-looking statements about candidates in development, including our mini dystrophin gene therapy. And so for any additional information, I would encourage you to go to Pfizer's annual report. All right, our agenda for today's session, we hope to do a few things. First, to provide an overview of Duchenne muscular dystrophy, to share an overview of gene therapy, to dip into our Pfizer's Duchenne muscular dystrophy clinical development program. Then we're going to hear from a clinician's perspective on treating DMD in the Hispanic community. And then above all, we want to provide an opportunity for you to ask questions and to share your insights. Okay, so in a virtual world, we're going to have some icebreakers. So we thought we would throw in a few polling questions. And Vincent's running that for us. Thank you, Vincent. All right, our first question is around diversity and inclusion. Which of the following aspects of diversity is least achieved in clinical trials, in your opinion? Ethnic or cultural, geographic, socioeconomic, or other? And we'll give you just a few minutes to answer. And I think Vincent let us know. I don't know if you'll be able to share the results on screen or we'll get them afterwards.
Oh,
okay,
there you go.
All right, fantastic. So it looks like ethnic and cultural right up there at the top, followed by socioeconomic and geographic. And for those of you that entered other, we would love to hear from you. Perhaps in the chat function, let us know as we go through the presentation, what are some of the other ideas you have around what we might be missing in diversity in clinical trials. All right, we have a couple more. Okay, this one is around referral patterns. What are some of the contributing factors for referral into clinical trials? Patient request, relationship with the investigator, proximity to the study site, a sponsor presentation, or maybe something else that we haven't thought of. So we'll give you just a few minutes to answer. Let's see, did that one close out? There we go. Okay, wow. 58% of you said proximity to the study site. And I think that as Dr. Johansson is going to share, that is a big issue, at least where he practices down in Texas. He'll share that with you in a little bit. That's followed by kind of neck and neck. Oh, sorry, with the proximity. Well, let's see, what were the questions? Relationship to, thank you, relationship with the investigator and patient request. Okay. Next polling question, I believe we have one more. And this is around, let's see, there we go. Some of the tools that you feel you might need to best facilitate the conversation with patients about gene therapy studies. Plain language resources or handouts, study website, information from patient advocacy groups, or other. Let's see, are we ready to see the results? We need some music playing in the background. Okay, plain language resources and handouts. And I should say that and in Spanish. So thank you. And if you have any other ideas, please put those in chat. And I think we're ready to move on to the first slide of the presentation. And thank you so much for your engagement. That's just a little bit of fun and also allows you to share some of your opinions and insights. All right. Thank you, Vincent. So Duchenne is a rare childhood genetic X-linked disease. It was actually first described in the 1860s, but dystrophin wasn't discovered as the cause of the disease until 1987. As I mentioned, the dystrophin gene is located on the X chromosome, and boys that are born to a mother with a mutated gene have a 50% chance of inheriting DMD. Now, the presence of one normal gene in women or carriers is usually adequate for functioning, but it can result in a mild form of DMD. While most of the mutations are inherited from the mom, there are also reports of spontaneous mutations, and often when there's no family history. Next slide. So the DMD gene mutations result in non-functional dystrophin. The DMD gene is one of the largest in the human body. It spans 2.5 million bases and it's comprised of 79 exons. And we have that represented on the right-hand side of the slide. The gene codes for dystrophin protein, and most commonly deletions of one or more of the exons lead to a frame shift, which causes downstream production of a truncated or an unstable or really a non-functional dystrophin protein. On the right-hand side of the slide, you can see for illustration purposes, this is an example in where exons 48, 49, and 50 are missing. There's a deletion. And so instead of having the full length protein, what you end up with is a shift in the reading frame. And so you actually have the truncated or non-functional dystrophin protein, hence DMD. Next slide. So dystrophin is important in muscle functioning, and it connects the inner parts of the muscle that contract to the surface of the membrane cell. And so when the contraction occurs, it pulls the surface of the membrane, and it is very fragile. And so we like to say that dystrophin acts as a rope or a shock absorber to protect that membrane. When you don't have functional dystrophin, and such as in Duchenne, what happens is leads to micro tears and cell damage, and then you get infiltration of fatty tissue and cell death and scarring. And that's what happens in the DMD patient. Next slide. We like to also say that really Duchenne affects the entire body. And I just want to highlight a few areas: skeletal muscle, heart, and brain. So for the skeletal muscle on the left-hand side of the slide, skeletal muscle atrophy leads to decreased strength and loss of mobility. And as you know, that's important for all parts of the body, but in particular for required for breathing. It can lead to progressive respiratory failure. We have some pictures here of what normal muscle looks like on the left, and then in the Duchenne boys on the right, that's a thigh muscle MRI, and you can see the infiltration and scarring of the fatty tissue and scarring on the right-hand side. We have staining and immunostaining at the bottom, looking at what a healthy normal muscle would look like versus what happens in the Duchenne boys. In the middle of the slide, we'll just talk briefly about what happens to the heart. Cardiac muscle involvement causes dilated cardiomyopathy and eventually death. 30% of DMD patients die from cardiac failure, and even the 20% of the female carriers have cardiac symptoms. Dystrophin is also in the brain, and lack of dystrophin in the brain can cause cognitive or behavioral impairment. And in fact, 33% of DMD boys have mental retardation. Their language skills are the most affected, and it can also lead to cognitive dysfunction, but that is not progressive. Next slide. So let's take a look at the prevalence of DMD around the world. It's estimated to be approximately 5 to 8 per 100,000 in the male population in G7 countries and emerging markets. Now, we have very good quality data, a lot of epidemiological data from the US, the EU, as well as Japan, and that data is very consistent. We are limited with some of the data that we have, epidemiological studies in emerging markets, and so there's more research to be done there. Back in the 90s, DMD was reported to be about 1 in 3,500 live male births, but most recently we've seen that re-examined, and that's now around 1 in 5,000 live male births, and that may be due to reproductive planning or perhaps even medical advances in diagnosing DMD. What I'd like to do before you switch to the next slide, Vincent, is actually dig a little deeper into the Hispanic population, because I know that's really our topic of interest tonight. And so to do that, we need to actually look into the CDC-sponsored MD StarNet data, and that stands for Muscular Dystrophy Surveillance Tracking Research Network. This was established back in 2002, and as of today, they have over 30 publications. And ironically, just last month, they actually published a recent paper, and that was in Neuroepidemiology in January of 2021. And what they were looking at in this publication was to estimate the overall prevalence, as well as the prevalence by race and ethnicity of Duchenne and Becker muscular dystrophy in males ages 5 to 9 years old. And what they found at the end of this study, their conclusions were that in males aged 5 to 9, and this is in the US, again, this is US data sponsored by the CDC, for those 5 to 9-year-olds, we saw, compared to non-Hispanic whites, they saw a higher incidence of Duchenne muscular dystrophy in Hispanics, and a lower incidence in non-Hispanic Blacks and non-Hispanic American Indians, Alaskan Natives, and Asian Pacific Islanders. So some of the reasons that the authors speculate why they saw a slightly higher incidence in the Hispanic population, they're not sure. They know they need to study this deeper, but perhaps it's delayed diagnosis or it may be a shift in demographics from when they had studied this earlier, that increase in census reporting in the Hispanic population. But again, they're just not sure. So they said they definitely need to study this more. Next slide. So let's look at the clinical course of DMD. The average age of diagnosis is about 5 years old. And so early in the diagnosis, what you see in these boys is that their motor function improves more slowly than their peers. And that's usually when the parents and the family caregivers start to notice that there may be something going on. They may have short stature. They may have language development issues, or their verbal memory may be delayed. And the other thing I wanted to mention that's not on this slide is the classic sign for DMD. You may have heard of it, the Gower sign or maneuver. And that's when these boys actually use their hands and arms to walk up their body if they're in a squatting position or on the floor. It's a very classic diagnostic sign or maneuver for DMD. It's called the Gower sign. As they get a little older, what you'll see in these boys is they have difficulty walking, they fall frequently. 50% of them will lose ambulation by age 11. And in fact, the average age loss of ambulation is 13 years old. You can see that different body parts and areas are affected, whether that be through contractures or their pulmonary function or heart, or they may have weight gain because they're on steroids treatment. As they progress and get older, as I mentioned, by about the age of 16, most of them are in a wheelchair, and then they start to lose the function of their upper limbs. They may also require ventilation in the evenings. They might see increased cardiac insufficiency, or even their swallowing may be affected. And unfortunately, the average age of death in these young men is 28 years old. And that's usually due to cardiac failure or pulmonary insufficiency, because there is a high risk of aspiration as these young men in their 20s to up to 30. Next slide. Unfortunately, the diagnostic journey is longer probably than families would like for it to be, or caregivers. It does involve several referrals before the confirmation of DMD. We have on the left-hand side of the slide, you can see graphically represented what happens from the patient down to final diagnosis, and then just some the bullet points on the right-hand side of the slide that I'll walk through. So when patients, or usually the caregivers, start to notice that there may be movement difficulties or abnormalities, they usually reach out to their pediatrician or maybe to a neurologist, but usually to the pediatrician, where the pediatrician may do a creatine kinase test. And that's really emphasized in primary care because it's cost effective, it's readily available, and it has a high sensitivity and specificity. So once the pediatrician may get some results back, then they're probably going to refer that patient over to a neuromuscular specialist or to a neurologist, depending on their geographic location. And I know that's something Dr. Johansson is going to speak to in the second part of the presentation. So the general neurologist or neuromuscular specialist will conduct additional tests. Usually, if the CK hasn't been conducted, they'll also look at liver enzymes, which may be suggestive if they're elevated for DMD. And then by the time they reach the neuromuscular specialist, who usually is the primary disease manager or owner of making the diagnosis for DMD, it could have been a few years by the time they make it there. And they'll do genetic testing or repeat some of the tests if they haven't been done, or conduct those tests. And usually what happens in these care centers is, as the disease progresses, a full multidisciplinary team comes in of specialists, including cardiologists, pulmonologists, behavioral therapists, physical therapists, occupational therapists, to manage that patient from a holistic approach. Next slide. So let's just spend a few minutes on the currently available treatments. Up until the 1990s, there were no pharmacological treatments available. And the young men, the boys lost ambulation by around 12 years of age and usually, unfortunately, died by the age of 20. Through the years, the survival curve, and you can see that down on the bottom right, actually has been improved because of some of the therapies that are available and quicker diagnosis as well. But steroids began clinical use in the mid-1990s, and now they're known as standard of care for Duchenne. That would be prednisone or deflazacort that we have here in the US. Deflazacort was approved by the FDA in 2017. It's been available in the EU for many years, over 30 years, but we have prednisone and deflazacort here in the US. These are oral agents, and they do help decrease inflammation. They decrease muscle cell degeneration, as well as slowing the decline in muscle strength. Now, as everybody on the phone knows all too well, they come with side effects, and that can include just some examples: weight gain, decrease in bone mineral density, which might lead to vertebral fractures. Of course, hypertension and behavioral changes as well. Next slide. This slide I pulled from the Parent Project Muscular Dystrophy, or PPMD, website just a few weeks ago. It's a snapshot of what we have available and what's in the pipeline when we're focusing on restoring or replacing dystrophin. And you can see at the top of the slide, we have 3 agents that are available in the US, exon skippers. And they've been available. One just was approved in August of 2020, and some of them are available for a few years. But the way that they work is only for a certain target percentage of DMD patients that have a specific mutation. So for example, anywhere from 10 to 15% of DMD patients might have that specific mutation, whether that be amenable to exon skipping 51 or exon 53 skipping, depending on the patient and the mutation. So again, 10 to 15% that might be receive some benefit from the exon skippers. Now, as we move down the page, you can see that there's a lot in development, whether that be preclinical all the way up to phase 3. Some of the ones include gene therapy, which we're going to be focusing on from Pfizer's, our presentation tonight. Next slide. So when we talk about genetic medicine, there are many different approaches, 3 of which just want to highlight. We have gene transfer, or adding a functional gene editing, which was when you permanently remove or modify or add a gene, and then gene regulation, which is when you modify the gene expression. Now, at Pfizer, we're focused on in vivo recombinant AAV AAV-based gene therapy. And there's 2 kinds. There's in vivo or ex vivo, but we're focused on the in vivo. And that's actually using that recombinant AAV capsid to deliver the gene into the cell nucleus. And you can see that on the left-hand side of the slide. We have it illustrated here graphically. So the gene is encapsulated with the AAV. It's then infused into the patient, and then it goes in and to the target cell for that action. Next slide. So let's dig a little bit deeper into our asset for DMD gene therapy. It is a mini dystrophin sequence, and it was selected based on a mild Becker's muscular dystrophy patient's gene sequence. If you look in the middle of the slide, you'll see what a full-length dystrophin gene looks like. The second underneath that is a Becker patient and what their gene looks like. And then at the bottom here, you'll see our mini dystrophin gene sequence. And the reason that we selected AAV9 capsid is because of a couple of things. One, AAV viruses, they are non-pathogenic, And the AAV9 target tissue allows us to specifically target areas of concern in Duchenne, skeletal muscle, as well as cardiac muscle. And we also have a muscle-specific promoter that's been added in. And if you look down on the bottom right-hand side of the slide, you can see that illustrated where we have the promoter or muscle-specific promoter, the dystrophin mini gene in here, which is encapsulated in that AAV9 capsid. Next slide. So right now we have an ongoing phase 1 study, and it is open label study, and it's in 3 sites in the United States by invitation only. And that's to look at the safety and tolerability of our DMD gene therapy in young men with Duchenne. We've recently expanded it to include non-ambulatory patients. And again, this is by invitation only. And the results from this ongoing phase 1 study were presented, interim results, back in May of 2020 at the American Society of Cell and Gene Therapy. What I want to point out is just an overall schematic here of the study design. Again, it's open label. There are 2 different doses, lower dose or higher dose, and patients receive the investigational product treatment for 12 months, and then they go on for long-term follow-up 4 years after the administration. Our primary endpoint is looking at safety through 12 months, and then secondary endpoints include dystrophin concentrations and distribution, as well as that long-term safety at 5 years. We are collecting muscle biopsies throughout the trial. And again, as I mentioned, the preliminary results were reported last year, and we also have some other functional endpoints that we'll be looking at. We did see at least a signal to move into our phase 3. And if you can go to the next slide. Thank you. And so this is our phase 3 global multi-centered randomized double-blind placebo-controlled study to look at the safety and efficacy of our gene therapy in ambulatory boys with Duchenne. This was just started recently, and if you'll go to the next slide. Thank you. It's called the Cifro Trial, and this schematic outlines the study design. We will have 99 ambulatory boys aged 4 to 7 with Duchenne muscular dystrophy, of course, randomized in a 2-to-1 fashion to receive active drug or delayed treatment, and then after 1 year, then the one that got the active drug will then receive placebo, and then vice versa, so that everybody does get the investigational product, and then they will be followed up for a total of 5 years after the infusion of the study drug. Again, it's for boys aged 4 to 7 years old. It is placebo-controlled double-blind study. And our primary endpoint is looking at a change in baseline to week 52 on the North Star Ambulatory Assessment total score. So we were really excited that this study, next slide, has just been up and running, and if you'll move to the next slide. Thank you so much. So we were very excited that our first patient was dosed at a site in Barcelona, Spain, right before the end of the year, December 29th, 2020. You can learn more about this trial on clinicaltrials.gov or also on our study website at cifroduchennetrial.com. So I believe that is the last slide for my presentation. Thank you so much.
Thank you, Angela. Now it gives me great pleasure to introduce our clinician, and he is Dr. Bert Johansson from El Paso, Texas. Bert? Oh, you're muted.
Angela, thank you for a wonderful talk. I feel like I need to burn the piano now. And I have to say, I'm not originally from El Paso. I'm a New Yorker. So okay. I know I do talk fast. You got to hear me in Spanish. It's even faster. I'm going to limit the number of slides, as all of us have survived medical and graduate school. I'm going to try to make this more case-based. But I first want to answer the question, why would a pediatric intensivist be interested in Duchenne's? Well, it's a pediatric disease. And oftentimes we in the ICU are support for our primary care doctors. Even before you would even approach a neurologist or a muscle specialist. And if you think about the differential diagnosis for weakness in a child, yes, it's Duchenne's, it's Becker's, it's Emery-Dreifuss, it's scapulohumeral. But it also includes botulism ingestion, it includes spinal muscle atrophy, it includes mitochondrial diseases, also lipid carnitine deficiency. So these are things that will end up in the unit eventually because of respiratory problems or a decreased likelihood of having respiratory disorders as a result of influenza or COVID-19. So, and I want to jump back to the beginning a little bit about why we ask questions. And having moved from New York City to the booming metropolis of El Paso, I became acutely aware of how geography affects how, as a Latino, I care for my patients. I left New York where there is a plethora of academic medical centers. If I wanted someone with a specific disease, let's say it's Duchenne's, not only would I get a pediatric neurologist who specialized in muscle, there was a really good chance I would get a doctor who was doing research on this as part of a project. So it's a little different down here in El Paso where we don't have an academic medical center. We have one neurologist, he's not a specialist. So this falls upon all of us to become subject matter experts. So wherever you're working, do that. But also, if you're a private practice pediatrician and you have a relationship with your Latino families, they're going to turn to you and say, doctor, what is this? So don't be scared to call and make yourself a subject matter expert. And the other issue that we have as Latinos, if you look at the data that Angela presented to us, that we are higher, but as Hispanics, we're in our pretty a different group. Those of us that have done 23andMe, we've realized that we're interesting mutts. When I was in New York, my patients were primarily Puerto Rican and Dominicano, and down here in the border, I'm dealing with Mexican Americans, which in a sense is disingenuous because as Mexican Americans, you were dealing with people who have a great deal of Native American blood, a lot of people who still have the Castellano, but also Mexico, especially along here, the border has a great many people who are of African American descent or of Arab descent who came over. So, and I think that's important. The second issue that we came up in the poll was how to get to people to these trials, which was very important because Latinos are underrepresented in many studies. And to me, the site locale is incredibly important. I decided, because I have a little bit of OCD, that when you take a compass and put it in Houston and put it in El Paso and turn it northward, you'd be almost on the Canadian border. So I have a great deal of problem getting my patients to a center. Try to explain to an abuelita that you're going to send her nieto to Houston. You better be prepared. And it's something that, again, we have to take into account as when we want to practice culturally appropriate medicine. And then the last one we talked about, I agree with the people who said we need language appropriate. But the Spanish I grew up speaking is very different than the Spanish they speak on the border. They call it puche, and they have very different words. And I don't want to be a cultural snob. I want to try to learn that language. And when you print something out, make sure it's someone local who did it, who can get to that language to reach those patients. Now, with everyone's permission, I'd like to get started with the first case. There you go. The first child is a 2-month-old infant, and he's coming in for a well supervision. He's tracting, he's smiling. He's got a great social smile. For those of you with children, that's a great time. Because all of a sudden, that crying child makes you feel better and you feel loved. He's holding his head up, which is a little early for someone because between 2 and 4 months. However, he has a 4-year-old sister who's developmentally normal, but the mom tells you that her brother died at 20 years of age with complications related to a muscle disease that she doesn't know the name of. She does remember that he had large calves, calf hypertrophy, and he used his hands to crawl from a lying to a standing position. And again, as Angela described, this is known as Gower's maneuver, Gower sign. He required the use of a wheelchair by 10. The mother reports he had no muscle weakness or cramps. She has no money. The mother underwent echocardiography 5 years ago for chest pain and was shown that she had mild dilated cardiomyopathy. I think we all know, since this is a talk on Duchenne's, that this is Duchenne's. The parents are concerned about their son's risk of experiencing the same condition. So what is the genetic likelihood of this child having that disease? And you can put your answers in, or I'll just, yeah, there you go. So given the time I'm going to move forward, it's 50%. Now, there is some variation, as you know, because there can be a spontaneous mutation on the X chromosome. And also in the female, we also know the lion, Mary Lyon came up with a Lyon hypothesis, was inactivation of one of the chromosomes, which controls for dosage compensation. So if you look at other X-linked disorders such as hemophilia A, and you look at their PTTs, you see that it ranges between 30 and 70%. We don't have the same corollary with Duchenne's, but we see the same sort of variation amongst women. I would also caution people that when you do give the diagnosis and you explain that it's X-linked, there may be a possibility that the family may blame the mother. And so I have a great deal of concern, and I'm very cautious when I talk about this, because yes, here in El Paso, I also have to wear the geneticist hat. As you take care of these children, you'll see that about 10 years of age, they do become wheelchair bound. And I do send a lot of them to physical therapy to try to keep it up, and it really helps. One of the biggest problems is respiratory. Even when they're on prednisone or the flax support, eventually they need some respiratory support. I try to start as non-invasive and just at night, which can be done with a BiPAP machine, and to escalate. I also use what's known as RAM cannula, which goes into their noses. But eventually, many of them end up with a tracheostomy, which can be a very difficult conversation with the family. But as many of you know, 50% of airway resistance is between the nose and the cricoid. So these actually freeze a lot of these kids up, and they may not be vent dependent during the day for a longer period since you took away that amount of work. However, especially in an environment such as here in El Paso, where we have a humidity that's oftentimes less than 10%, you have to be very careful about secretions clotting in the trachea. Additionally, because they do have some upper respiratory issues, they actually may have trouble controlling their secretions. And yes, I've used glycopyrrolate. I started in the hospital, and I'll tell you why. About a third of the patients get better. About a third have no effect at all. And ironically, about a third get worse. Some of these kids, I do give a diverting spittostomy where the spit can come out. If you do have the trach and you do have a cuff, you can keep that there. Many of these children also end up with a G-tube to be fed, which again, in the Latino community, given how important food is, this can be a very trying time for the family. But eventually these children often end up on more full-time, some kind of ventilator support, going from continuous positive airway pressure to actually BiPAP with a rate. The thing to look for that gets you very concerned, and again, initiating conversations with parents, is that the patients will start to present with tachycardia. And as we know, heart rate times ejection fraction gives you cardiac output. Well, as their muscles begin to fail, the only way they can keep up their cardiac output is increase the heart rate. And this eventually leads to heart failure. I bring it up because, again, those people who have a good relationship with their patients, the primary care doctor, the long-term neurologist, this is a time to start having an end-of-life conversation. And I often at this time put on my palliative and hospice care hat and begin to talk about a comfortable end. And by the way, Angela, I look with great anticipation for your med to come out because I hate having those conversations. So can I look at the next case, please? So the next case is a much older boy, and again, a more common presentation. Because quite frankly, if I think I'm most 2 months old, unless I get a history like that, I'm not necessarily thinking DMD. But this is a little 4-year-old who, who's being evaluated for developmental delay. But that's not necessarily a sine qua non for Duchenne. Many of these children are actually neurologically intact. The mother reports that she became first concerned about his development around 18 months because he had just begun walking. And in this particular case, he was having trouble walking. And as Angela pointed down, lots of falls. Again, those of us who had children know kids fall, but sometimes they fall a little too much. At 2, he was unable to jump with 2 feet, could not run or walk upstairs. Again, walking upstairs is usually a big hint about proximal muscle weakness. His fine motor and social and language development are normal. He's been receiving physical therapy with minimal improvement in his gross motor skills. And this should be a big black flag. On physical exam, you find he's alert and playful. His cranial nerve exam findings are normal. He has prominent calves. And I believe there's a picture here to look at the hypertrophy. There you go. And this is a picture of a real patient. This is not uncommon to see this kind of hypertrophy. And again, if you press on these, the muscles are not particularly hard. There is usually no pain. They're usually quite well perfused. However, when you do his strength testing, like pushing up for his both pronation and flexion, it's usually pretty much normal at that point. And his reflexes are usually normal at +2 bilaterally. And there's no Babinski sign. And as I say in my case, the sensation to light touch is intact. He has a normal gait, but when asked to rise from the floor, we get the other picture, which is a kid in the terminal phase of Gower's sign. And what you'll often see is these kids will rock forward, bring their legs underneath them, and then literally push up, a clear sign of muscle weakness. Now, the question I have here is, what is the first test? And as Angela pointed out so very nicely, it's a creatinine kinase. And I have to tell you, when I've been called sometimes for consult and asked for that, I sometimes get very perplexed look, because people are thinking these other things. They're thinking a muscle biopsy, which I rarely use now, in part because I don't have a pathologist here to read it. But even in New York, I moved away from it because I had genetic testing. But creatinine kinase, if normal, you can move away from the diagnosis of DMD. It should be markedly elevated, 100 times normal. Many people ask, why don't you get a brain resonance imaging? Well, part of the differential diagnosis there are some things you may want to do that. But this kid's physical exam is localizing the lesion outside of the brain, in fact, outside of the central nervous system. And this is an important thing to do. Now, EMG is something that we don't always do in children, indeed, because they oftentimes need to be sedated. It is not very helpful here because this is a muscle disease and not necessarily, it would show up in an EMG or nerve conduction, because again, that would be motor end plate or nerve disease, which you may see in SMA or in another illness such as Guillain-Barré syndrome. So what I'd like to do is spend a moment, where we go, with moving toward other things about genetics. And I just want to make a point. Yes, this is an excellent illness, and as are the mitochondrial illnesses. I cannot emphasize enough to also look at the female children who, just like Fragile X, just like hemophilia, may have some of the syndromes. And that's an important thing to do in the family. This mom was picked up because she had chest pain and they thought she was having myocardial infarction. And we were able to get her on appropriate meds to increase her cardiac output and deal with the dilated cardiomyopathy. And just as a matter of point, you can also see this in your cystic fibrosis children. If you have children who are homozygous for Delta F508, their siblings indeed have a half chance of also being heterozygous for it. And they may have, depending on how much the genes are inactivated, several, if not many, of the symptoms and signs of cystic fibrosis. In fact, it's known as CF metabolic syndrome. Just to be aware in a general place. What I'd like to do now is turn it back to you, Angela, and we can start dealing now with questions, because I really wanted to make this question oriented and help everybody get on the same plane.
So thank you, both of you, Bert and Angela. And I see there's a whole list of resources here. This is great. We will have the recording of this webinar and all these resources on our website. I saw a few questions, and I have some questions too. Let me just say one question, Angela, you might want to just answer this one. Is, can the diagnosis be made at birth for for Duchenne's muscular dystrophy?
Yes, and so it definitely can. And in fact, there is a pilot in New York State where that is happening. In fact, Dr. Johansson, you might be familiar with that.
Yes, I'm sitting here laughing because you're the first person outside of New York that has actually mentioned it. You know?
Were you involved with it at all when you were there?
No, I wasn't. I mean, I did. I was on a committee with the AAP in conjunction with the New York State Health Department, which is being run by an incredible guy named Howard Zucker now, who really wants to push early genetic testing. And again, now that we have a medicine that's Pfizer is it maybe work better if used earlier, as we're seeing with SMA. These kids are being diagnosed in the first 6 months of life. Given that SMA type 1 has a 6-month lifespan, we may be able to totally change the course of the disease. So I am looking at Pfizer's work with great anticipation. And again, with early diagnosis, even greater anticipation.
Yeah. And I
Great.
think, thank you. And, it can be done. I just think right now it's just not on the newborn screening panels, in most places around the world or here in the US. But we do have that pilot going in New York that I'm aware of.
So let me ask Angela this question too. You referred to the population around the world and the importance to know that the incidence is happening in higher in the Hispanic population here in the United States. Do you have can you refresh our minds here on what that incidence is, or how high it is compared to others?
Sure. I don't have a slide on it. But what we could do is at least maybe put in the follow-up at least the citation so people could go and read it. It's not much higher though. The study that was done, what they looked at is, I'm just trying to review here. So they looked at over 1,000 patients with Duchenne or Becker muscular dystrophy, and it was a 5-year prevalence in those 5 to 9-year-olds. And so for the Hispanics, it was a prevalence of anywhere from 2 to 4, depending on how they did the study. And then when you look at the non-Hispanic whites, it was around 1.78 to 2.2, so slightly higher. And again, there was a lot of different statistical analysis. They actually did 3 different estimates on this, but it appears to be coming down. It's what the authors concluded. And again, some of those reasons that they speculate perhaps is because when they did the initial work, the denominator did not include the entire Hispanic population because of maybe the census. Everybody hadn't been counted for. So they feel like now maybe that's had been falsely elevated. That was one of their speculations. Dr. Johansson, do you have anything to add there on that?
Yeah, again, as I've learned, we have, in Spanish, we describe each other as güeritos, blancos, trigueñitos, morenos, chinitos. And we do it because we're just really cool people. And it's the point I'm trying to lead up to is we are racially mixed. We have, working here on the border, I'm more likely, as likely to hear someone speak Guanani as I am Spanish. And the Talamura Indian, Native Americans, First Nation people are basically unstudied. I mean, people know them because they're the great long distance runners. But as far as I just happened to discover that in a place called Matamoros, there's a high incidence of Tay-Sachs. And indeed, it's the Ashkenazi gene, which may mean that people are bred, but they're living in basically genetic allopatry. And I think as we take care of Latinos, we have to be aware where they come from, their ethnicity, and that they may actually be genetically very mixed or living in an allopatric area.
I have another question for you, Bert, or Dr. Johansson. You mentioned about having the disease often is X-linked, and to be very careful not to blame the mother, that it's not the mother's fault.
Amen.
We usually think of the X genes for the female and the XY, for the Y for the male. Could you tell us how you talk to the patients and their families? Because we know that for Latino families, they all want to know what's going on, and it's important, and really for our families, the mother is always on a pedestal, and we don't want to have ill will to our families when people start sensing that you are blaming the mother for this disease that the family has to take care of, right? Everybody has to get involved. So how do you talk to them about this X link?
Well, the first thing is I talk to the whole family. And I got in the habit many years ago of walking into a room, usually filled with 42 people, a small Mexican family. And I approached the oldest lady and go, "Hola, ¿cómo está, señora? ¿Tú eres de mamá?" And she goes, "No, doctor, yo estoy de bisabuela." And the reason I do that is, I asked the oldest woman if she's the mom. And for those of us in my family, my Abuelita ran the family. For those of you who believe that a Latino family is run by men,
Grandmother.
yeah, the grandmother. So I try to make an ally with them, but I also try to figure out how much do they know. I often find out the abuelita knows who died, who had this. I mentioned the children with Tay-Sachs. It was the abuelita who was able to tie together the people in her village and how they had gotten it. Sometimes I don't have that. Sometimes we had, this is, no one knows, they were, the family doesn't go on. So once I used to try to talk with the mom alone, and I try to find out what her family's like. I try to find out what she knows about genetics. Many of my patients here on the border never went to school. They don't understand chromosomes. And I have to admit in public, and remember my real name, Elena Rios, I sometimes don't tell patients because they're not in a place to understand, and they self-blame. I've had moms try to commit suicide because I can't believe I brought this on my child.
Yeah.
But to answer your question directly, the blame, and it's just, you know, I was raised by my grandmother who reminded me that God gave his only son a mother. And so that tells you the closeness, which I am as a Latino proud of. So to answer your question directly, I go in, I do a little reconnaissance. What do they know about the disease? Have there been other children affected? And I sit and I talk to the mom alone a long time before I let the diagnosis out. And I always re-emphasize, this is not your fault. And
well,
it's all,
you know, let me go back to Angela. So you mentioned the new clinical trials, the studies that happen for our patients, especially Latinos, to start getting more involved with. Angela, is there a website that someone can help get involved? We have a question about the interest in how to get involved with your clinical trials that you mentioned.
Absolutely. Thank you. So right now, I encourage you to go to clinicaltrials.gov, and we can make sure that, I think it's in the slides, or we can put it here in the chat as well. As sites start to open up, that is the best way to find out about a site near you. And we get, as soon as we have them opening up, we're putting it on clinicaltrials.gov.
Okay, great. I also wanted to ask Bert, another question came in, is how can we help the patients, not just the patients, their caregivers, to be more compliant with treatment? And, you know, it may be respiratory problems. And if you want to, you gave a great synopsis of all the different respiratory supports that you know of, that you do for your patients. But, you know, the patients have to come back to you to tell you that it's working or not working. And how do you get them to come back? How do you get them to really be, you know, a team player with you?
one of the things that I had to learn moving here to the border, because in New York, you know, my patients lived in the neighborhood around Columbia, and I could often walk, make a home visit. Part of the problem I have here on the border is many of my patients live on the other side of the border, and I don't like calling other human beings illegal, but may have trouble crossing back. And as you know, I've gone to Juarez. And again, there's also sometimes a disbelief and a distrust. And we have to build and work on that and show them that as their children get more support, that they are doing better. And I was very happy to hear someone, how do we help them? I was very fortunate that one of the board members of Apostle Children's Hospital's son was affected. She's open about it, written. And she would come and talk to moms and help us and help get people involved. And also, I am not scared to use the Abuelita network. If I find a mom's not doing the job, I call Abuela. And, you know, people laugh, but again, I'm a proud Latino, and tú eres Mexicana, so you know what I'm talking about. You get Abuelita involved, and you'll be amazed what happens.
So honestly, that's a great secret there. Another aspect of this disease, and it is about children and young kids especially, and dealing with the young mothers, and all of the anxieties really take a toll on our doctors and our nurses too. But, you know, and this period of time in our history with COVID-19, where we're seeing so many healthcare workers burn out. How do you deal with burnout when, you know, being a pediatric doctor that takes care of so many severe cases?
Well, first off, I love being a pediatrician more than anything in the world. You know, I was one of those people when I graduated from medical school. You know, most people got the golf clap. Roberto, Emilio Lefebvre, Pacheco, Johansson. My entire family showed up and were screaming and shouting. And I go back to that. And the reason I go back to that is I have had to tell children throughout my career, parents, you know, they have cancer, accidents, they're brain dead, give me organ. And the children really do die once at the diagnosis, two when they get worse, and then one when they actually die. Now, as far as not doing burnout, honestly, I do a lot of working out. I go to the gym. I happen to be married to an incredible woman whose father was a cardiac surgeon. So she is an incredible support. And unfortunately, for those of you who aren't members of NMHA, one of the hidden secrets about NMHA is I have members calling me. They heard how bad COVID was down here. And I got, you know, we have one of our members is a psychiatrist from UTRGV. Hey, Beto, how are you doing? And he calls me once or twice a week just to see how I'm doing. We have other colleagues in San Antonio who call. I have colleagues from New York. So one, you know, talk about it, realize it's there, and make sure you got a support network. And as doctors, you know, we have some problems sometimes with medication and having our egos get in the way. And avoid both of those and use your support system. And again, not just because I want people to join NMHA, it has been an incredible resource for me, both in terms of getting information that I need, but also just being able to talk to another doctor who says, you know, who knows what we're all going through. Does that answer your question?
And thank you. And just to put a plug in, we are going to discuss physician burnout at our national conference that will be in March. And it's something that we recognize with diseases that affect so many in the families that we take care of, right? That you've got to be able to understand how to take care of yourself too. Angela, you're from Pfizer, and Pfizer has done an incredible job with so many clinical trials and so many medications. Tell us about this new medication. When is it going to be out? What's the timeline for something new that you mentioned? I didn't quite catch the name. Anything you can tell us?
Sure. Well, thank you again for allowing us to join you this evening. So we're just very early on. We are just starting the phase 3 trial right now. First patient dosed in Spain at the end of last year. And so we're ramping up, adding in more sites around the world. It is a global trial. And so but the way that phase 3 trials go, it's long term. So it'll be a few years before we'll have any results that we are able to share, and then the whole, if it goes well, and then filing and hopefully approval. But it won't be really none too soon for the families. I know everybody is desperate, and it's such a huge unmet need. And so we are working very hard, everybody at Pfizer, to get this study up and running so that we can move things forward as quickly and safely as possible.
Oh, that's great. And I imagine that you have partners with patient advocacy groups. Could you tell us about, one of the questions was about Spanish language materials. I would also like to know if you have support groups for people, the families, the mothers who are Spanish speaking, especially in places like Texas, California, and others, where we do have immigrants who aren't literate in English, and really do need to talk to somebody about how they, lessons learned, right? And taking care of little kids that can't move as well as their older brothers and sisters.
Mm-hmm.
Yeah, so important. The patient advocacy groups do a fantastic job. And I know Vincent put together some nice resources on that last slide for 4 or 5 different organizations that have Spanish speaking materials. They have, let's see, thank you, Vincent. He's going to pull it back up. They have, in fact, just for an example, we were part of one with PPMD in December, where they actually had 2 different groups going. We did a webinar, and there was one just for Spanish speaking families and one Zoom breakout, and then one for English speaking families. And these were families that lived in the Miami area. So I know all of these organizations are working very hard to provide that support for patients and families in different languages as well. So.
Oh, that's great. I think it's so important to be able to provide education, and these webinars that we're doing not only have excellent speakers with information, but we have to provide the follow-up on where to go to get more help, to get more education. Just one more question, Bert, given that we're waiting for the next generation of medications, and you mentioned treating some of the issues that happen with your patients. One of the things you mentioned again was I want to get back to that respiratory problem of secretions. Could you explain what you think works best, knowing that everything's a case-by-case approach, but what are the 2 or 3 methods that you use to help decrease secretions in young kids that can't really swallow?
I think a trial of glycopyrrolate is worth it. Try to use the lowest dose possible, because as you know, even though they say it doesn't cross the blood-brain barrier, you still get peripheral effects. And I would absolutely do that under a supervised situation in the hospital, because again, about a third get worse. And I try to leave them that on as long as I can. A diverting spectroscopy is invasive surgery, and I try to keep these kids out of surgery. Again, because of the rehab, getting their lungs reinflated and getting them back to where they need to be can sometimes is prolonged in these children. In fact, I do go through a great deal of effort to try to keep them from being intubated. In fact, we actually, in New York, we had a protocol for extubating kids with muscular dystrophy, including Duchenne's. So I have a lower threshold to go to trach. One, again, because it cuts it down and still gives the child some mobility. And many of them still have the strength to be able to use a passive mirror valve and still be able to speak. And if you do use the trach, you can use it with a cuff so it doesn't end up in their lungs. Very rarely, if you have a really good IR radiologist, you can find a good use for Botox and actually go in there and inject it into the salivary glands. I've actually had patients that work for 3 to 6 months. And on the second or third round, it actually lasts longer. I was told by the Botox makers that I'm not supposed to say that they think it's killing salivary glands, but I think it's killing the salivary glands. And in these patients, it's a good thing because I can always hydrate their food. So that's my order: glycopyrrolate, consider trach, and if you do have an IR person, then they can actually use Botox in the salivary glands, and it really improves their quality of life.
Oh, that's good. That's really good to know. Thank you. I think that there's a lot of information that you've given to people tonight on this terrible disease for young kids, but a disease that we have to realize is very prevalent in our communities. And I think it's important for everybody on the call to let families know about this and our other webinars that we have also, just to educate, especially the Latino community, from our experts. I don't have any other questions right now. I don't know if do you have anything else to say, any closing remarks, Angela, Bert?
Thank you all so much. This has been fantastic. I know I've learned a lot tonight, and just appreciate everyone's engagement. I know it's tough in a virtual situation. And again, a big thank you to Bert and everyone at NHMA. Really appreciate it.
Bert, did you want to say something else? And then we do have a slide, I think, a little.
Again, I just want to thank you, Elena, for doing this. It's important for our community to get this out. Angela, thank you for including me in this. I do want to be able to, I do give information about clinical trials to my patients when the patient's young enough. I don't want to give false hope. So again, just thank you for doing this. And also to anyone out there, if you need to get in touch with me, because I grew up in medically in an environment where we hung together. Medicine's a team sport. Email me, call me. Elena knows how to get to me, and I'll help you as much as I can. The worst thing I can do is try to steer you towards someone else who knows more than me, which is most people.
Yeah. Okay. Well, we have a couple slides just to close out. Vincent, did you? Don't know if you put the poll, the evaluation poll, or is that? No? Oh, okay.
Okay.
This is, yeah, we wanted to be sure and ask people that are on our webinars to provide us a little feedback. And we just wanted to know, did you learn something new that you will use in your practice or in your career or with your families? And if everybody could just answer that, we don't have to show the, this is anonymous, we don't have to show the results, but we just would like to have everybody sign that. And then the other question is, what are key messages that you give to your patients to get them to come back? Adherence with treatment, any treatment, whether, you know, for this disease especially, the treatments to help the young child with respiratory breathing or with you know, the GI feeding tubes and other things that can help. If mothers don't bring their kids back to the doctor, they won't get the treatment that can help them. And we all know that medications, you know, have to be prescribed by doctors, and you have to go to a pharmacy to pick it up. And, you know, it takes a lot of time away from your other duties as a mother or as a father. And it does take a lot of time to do all the healthcare management that your doctor asks you to do. But we'd like to know, what are key messages that you think we need to know about and share to get more of our patients to actually comply and to go back to the doctor, go to the pharmacy, get the medications, et cetera. And to please answer that in our chat box. So I'm closing that down, but if people could just answer us with a couple of words, sentence on how you talk to your patients about the importance of adherence, or compliance is another term. So we do have the last slide there that talks about the connections with our organization, the National Hispanic Medical Association. Again, we have our website there, nhmamd.org. The recording of this webinar and our handouts, especially the important patient advocacy groups that have Spanish materials, will be on our website next week. We also have our national conference coming up, and I think just so people know, it is virtual like this. We will be recording it, but we have an agenda on that website now. The conference is in a month, March 17th through March 20th, and this is actually our 24th annual conference. I can't believe it, but and we have lots of great speakers like tonight who will be joining us on sharing their expertise on a myriad of diseases for children's health, as well as women's health, as well as things that we touched on today: physician burnout, mental health issues, and issues really surrounding COVID-19 and how we can increase the vaccinations in our community. So the conference is really a really great time to hear about Hispanic health, and also to meet people that are very passionate, like Bert and Angela, about what they do and how we can build our networks with all of you. So, again, if, oh, here's the conference flyer. You can see people in the pictures. And I think that we've had a great webinar tonight. I want to thank Angela, and I want to thank Bert. I want to thank Vincent for helping. I also want to thank Pfizer for supporting us in this, for this webinar. And thank all of you for hanging in there. And I think that, let's see, I just saw there's a third-year medical student in El Paso on the call, Bert.
Yes.
You have to connect.
I'm going to reach out to Dr. Nieto.
Yes, I hope you do. So anyway, we're very, very lucky to have been able to have a great audience and great speakers. So. And another Hispanic nursing student in New Orleans. Okay, great. Well, you know, look on our website for our future webinars, and we will continue to build our networks and educate people about the importance, in this case, with muscular dystrophy, the Duchenne's muscular dystrophy, and how important it is to take care of not only children, but the mothers and all the caregivers who take care of children with these, with the problems in the journey that they have to go through with muscular dystrophy. And thank you again to Pfizer for supporting us. Thank you.
Elena, could you stay on one moment? I have a question I need to ask you.
Well, we're live on Facebook. Is that okay?
Yeah, I mean, I'm going to go ahead and ask you now.
Sure.
Texas is passing two laws, House Bill 68, which will make any care to a transgender child under 18 years of age. It promotes it to the level of child abuse. They also have House Bill 1399, which will relieve any insurance company for paying any transgender care. And as you know, there's a high rate of suicide amongst transgender and LGBT Hispanic youth.
Wow. Okay, well, you know, NHMA advocates and sends letters in to our policymakers, especially in places where it will impact our Hispanic community. So Bert, I'd be happy to talk to you afterwards. I have to say that we just supported the efforts in Congress right now to help our COVID relief bills that are being discussed and should be moving forward this week. So we're really happy to be able to advocate.
Oh, I love you,
Thank
Elena.
you, Bert.
Thank you.
Okay. Thank you, Angela.
Thank you. Good night.
Thank you, Vince. I'm going to sign off. Okay. Thank you.